far as today's topic is concerned, I think neurology and radiology go hand in hand, and it has come to a great developmental stage, right from X-ray skull, where they used to diagnose enlarged cella, to now 7 Tesla MRIs. So neurology has progressed along with radiology. And if you follow Neuro Twitter, I think every other day you will find some new development coming in the field of radiology. So today we are here to take synopsis or summary of what has been developed in last decade or so in the field of neurology. So without wasting much time, I think we should start our symposium. And the first lecture is MRI sequences basic for a neurologist. And our opening speaker is Dr. Nidhi Visana from Ahmedabad. She has done her MD radiology from Bombay Hospital, and she has done fellowship in neuroradiology from Sion Hospital. And at present, she is working in Safal Diagnostics and Imaging in Ahmedabad. So I welcome Dr. Nidhi for her talk. Thank you.
Okay. A very good morning to all. I am Dr. Nidhi, and I am here to talk about the first topic for today, which is MRI sequences. So I'm sure most of us know about the MRI sequences, and this might be just a revision for most of y'all. So there are over 100 of sequences which have been described in MRI. So the basic sequences are these, which are used in neuroimaging. So these are the basic sequences in brain imaging, which are T1, T2, FLAIR, diffusion, and GRE. And along with it, in spine, STIR images are also used. So a combination of various sequences form protocols. These are not official protocols, but then these are written on the requisition forms of patients, which help neurophysicians or physicians to communicate with us radiologists what they are suspecting in a patient and what needs to be imaged in a particular patient for their diagnosis. So coming to basic sequences, let's start with the sequences, and I'll be talking about the imaging appearance of the various sequences and their utilities. So first sequence is T1. So T1 is recognized where the CSF is dark and the gray matter is darker as compared to the white matter. So T1 sequences are used for delineating anatomy well. So the normal structures which are hyperintense on T1 include the posterior pituitary, which appears bright, and gadolinium contrast, which appears bright on T1 images. So the abnormal structures which are hyperintense on T1 include fat. So this is a case of quadrigeminal cistern lipoma, which appears hyperintense on T1. And this is a case of late subacute hemorrhage in the basal ganglia on the right side, which is hyperintense as well. This was a case of metastatic melanoma, where there are hyperintense metastasis in bilateral brain parenchyma. And this was a case of manganese toxicity in a patient. So there are bilateral hyperintensities on T1 images in bilateral basal ganglia. So coming to T1 hypointensity, so normally the flow voids are T1 hypointense. So on the right side, on the left side is the hypointensity in the left transverse sinus, which is normal. And on the right side, there is slight hyperintensity, which should help us suspect that there is some abnormality going on there. So abnormal structures which are hypointense on T1 include edema, tumors, infection. So this is a case of abscess which was hypointense on T1, and this is a case of low-grade glioma which appears hypointense, and this is a case of hyperacute infarct which was ISO2 hypointense on T1 images. So one variation of T1 imaging is T1 fat-sat. So T1 fat-sat is where we suppress the fat so that structures are seen more nicely. So this is one example where we are suppressing the fat and the contrast enhanced granulomas are well seen. It is also used to differentiate between fat and hemorrhage. So this was a case of lipoma, and on T1 fat-sat it becomes dark, which means fat is getting suppressed and hence it is fatty in nature. So T1 fat-sat images are also useful in differentiating dissection and identifying thrombosis in vessels. So this was a case of vertebral artery dissection on the left side. So this is a normal T1, so there is slight hyperintensity on the left side in the left vertebral artery, and on FAT-SAT images, this T1 hyperintensity is well delineated because rest of the fat is suppressed and the hemorrhage appears hyperintense. So another application of T1 images is in dynamic post-contrast studies, which is particularly used for pituitary microadenomas. So we inject IV contrast and various phases of scanning is performed, and the microadenoma stands out as a T1 hypointensity in the pituitary. So this is one example of pituitary microadenoma on the left side of the pituitary. So T1 imaging is also used in Parkinson's protocol. As I said, it is used for delineating anatomy. So we take thin sections through the midline and we calculate the area of the midbrain and the pons, and that is used for calculation of Parkinson's index in cases of PSP. So T1 is also used in dementia protocol, where we take 3D images of T1, 3D images of the brain in T1 sequence, and we can demonstrate hippocampal atrophy and atrophy of the parietal lobes for calculation of Quedam score, and that is what is all reported in dementia protocol. So the next basic sequence is T2. So T2 is identified where the CSF is hyperintense and the gray matter is hyper as compared to the white matter. White matter appears slightly darker on T2 images. So the normally most of the abnormal structures are all hyperintense on T2, which includes edema, tumor, infection. So this first case is a case of granuloma and there was surrounding edema which appears hyperintense on T2. This is a case of metastasis where the lesion itself is heterogeneous and surrounding edema is hyperintense. So that is how we suspect that there is some abnormality going on there. And this was a case of late subacute hemorrhage where centrally the hemorrhage is hyperintense and surrounding there is a rim of hemosiderin deposition. This was late subacute hemorrhage. So the next normally the flow voids are also hypointense on T2, and I think this is much better, hypointensity of flow voids is much better appreciated on T2 than T1. So this is the normal flow void of the superior sagittal sinus, and this is a case of cerebral venous sinus thrombosis where the flow void of the superior sagittal sinus is not visualized. So this should be black and this is hyperintense on T2. This was another case of cerebral AVM in a child. So there are multiple flow voids along bilateral MCA cisterns and in the basal cisterns, and a prominent flow void of the superior sagittal sinus is well seen over here. So abnormal structures on T2 include calcifications, melanin protein rich substances. So this was a case of Farr's disease where there was calcification in bilateral basal ganglia and thalami, and this was a case of acute hematoma which is hypointense on T2 images. So one variation of T2 imaging is heavily T2 weighted sequence, which is CIS or Fiesta. So different names on different machines. So this is a thin sequence which is used for identifying vascular loops, especially when it is prescribed in cases of trigeminal protocol or the 7th-8th nerve protocol. So this was a case of dolichoectatic right vertebral artery which was indenting the right trigeminal nerve near its root exit zone, and there was resultant thinning of the trigeminal nerve, and this was the prominent vascular loop which we are seeing on the sagittal images as well. CIS images are also used for differentiating between intra and extraaxial lesions. So this was a case of schwannoma where the fluid cleft sign is seen very well, and this is a case of intraaxial glioma. So this is an intraaxial lesion and there is no fluid cleft sign over here. So thin T2 sagittal sequences are also used in NPH protocol where we take midline thin sequences, and the flow void across the cerebral aqueduct is very well seen, and it is also seen across the fourth ventricle as well. So the next basic sequence is FLAIR. FLAIR is a variation of T2 but the CSF is suppressed and the CSF appears dark. So most of the abnormalities are very well seen on FLAIR. So edema, subarachnoid hemorrhages are the first things that we will discuss. So this is a case of granuloma. There was hyperintensity surrounding it which was suggestive of edema, and this was a case of subarachnoid hemorrhage, and there was hemorrhage along the sulcal spaces which was well seen on FLAIR in the right temporal region. Also FLAIR imaging is helpful in detecting periventricular lesions because of the contrast between the lesion and the dark CSF along the ventricles. FLAIR is helpful in detecting lesions in this region. So this was a case of tuberous sclerosis, and there are small subependymal nodules along the ventricular margin. And this was a case of multiple sclerosis. So along the callosocaptal interface, demyelinating lesions are well seen. So FLAIR is also helpful in distinguishing between chronic lacunar infarcts and VR spaces. So there is a thin rim of hyperintensity on FLAIR along the lacunar infarcts, chronic lacunar infarcts, and there is no hyperintensity seen around prominent VR spaces. So the next basic sequence is DWI and ADC, diffusion weighted imaging and apparent diffusion coefficient. So it is based on the principle of Brownian motion of water molecules. So anything that will have high mobility will appear dark, and anything that will have low mobility will appear bright. So this is a case of acute infarct, where the infarct has restricted the water molecule movement, so that is appearing bright, and the corresponding ADC values are calculated from it, and the image on the ADC for infarct would be dark. However, not all things that restrict are infarcts. So here's a list of causes of restricted diffusion, which include ischemic, apart from hyperacute infarct, subacute infarct is also appears dark, bright on diffusion weighted images, and there are non-ischemic causes as well. So this is an example of abscess which restricts on diffusion, and corresponding low signal intensity is seen on ADC images. This is another example of herpes encephalitis, where there is restricted diffusion in bilateral medial temporal lobes. And this is a case of lymphoma. Due to its high cellularity, it is causing restricted diffusion. So the phenomenon of T2 shine through is related to diffusion weighted imaging. So everything that is so in subacute infarcts, because of vasogenic edema, corresponding low signal intensity on ADC value is not seen. So this is a case of small subacute infarcts in the cerebellum and left occipital lobe, which are also hyper on ADC imaging, so suggestive of vasogenic edema, and this is the phenomenon of T2 shine through. So the next basic sequence is GRE and SWI. So GRE is a basic sequence which is used to determine detect hemorrhage and calcification, and also fat. So this is a case of subarachnoid hemorrhage in the basal cistern, and this is a case of a small calcified granuloma along the periventricular margin, and this is a case of lipoma which blooms on GRE because of chemical shift artifact. So SWI or SWAN are different names on different machines, and it is a 3D sequence which is somewhat similar to GRE, but then it is much more advanced, and it is a combination of phase and magnitude images. So advantages of SWI is it helps in detecting many more lesions. So this was a case of cavernous malformation where there are almost 3 or 4 lesions seen on GRE images. However, there are multiple, around 8 to 10 lesions seen on SWI. Also, this was a case of FARS where the calcifications in the thalami are much more better appreciated in on SWI images. SWI is also used for distinguishing hemorrhage from calcification, and that is possible on some machines. So SWI is also used in neurodegenerative disorders. This is the typical swallow-tail sign which is described in cases of Parkinson's disease. So inverted V appearance is a normal appearance on SWI, and it is lost in cases of Parkinson's disease. So along with T1 and T2, STIR images are used in spine imaging, which is a fat suppressed sequence, and STIR is also used in orbit and optic nerve imaging. So this was a case of trauma. So there is a lot of inflammation and edema in the retroorbital fat on the left side, and this is a case of optic neuritis where the signal intensity in the optic nerve is very well appreciated on STIR images. So STIR in spine is used for detecting metastasis, which is well demonstrated over here. So coming to some specialized sequences, brain and neck angiography. This is particularly used in cases of stroke. So where there is suspicion of infarct or hemorrhage, we do angiography. There are 2 prominent kinds. One is the non-contrast, which is the TOF, and contrast angiography is used whenever there is doubt in cases of plain imaging. So angiography is useful for detecting aneurysms. This is a case of right PCA aneurysm which is seen over here, and in cases of stenosis as well. So this is a case of left epithelial territory infarct, and on neck angiography there was significant stenosis of the left ICA, which was well appreciated on the angiography study. So brain venography is done in cases of cerebral venous sinus thrombosis. Again, it is of two types, plain and the contrast one. So it is useful for demonstrating thrombosis. This is a case where there was thrombus in the right transverse sinus, and this is the plain venography which showed that there was some filling defect over here and loss of signal. And this was the contrast venography which confirmed that there was no filling in the right transverse sinus, confirming thrombosis in this patient. So brain venography is also used in cases of IIH, intracranial hypertension, for demonstrating stenosis along the distal segments of bilateral transverse sinuses, along with prominent perioptic CSF spaces and empty sella, which is seen in this case. So some specialized sequences also include MR perfusion. So it is used for assessing perfusion of tissues, and a sequence is run along when either contrast can be injected or a plain sequence is run, and various parameters are calculated. And this is particularly important in cases of hyperacute acute infarct to determine the ischemic penumbra, and in cases of neoplasm to detect the grades or whether there is recurrence post radiotherapy, and also in some neurodegenerative diseases. So we have been doing and trying arterial spin labeling ASL, which is a non-contrast MR perfusion in some of our patients. So this is the first case, which was a case of hyperacute infarct. So on diffusion and ADC, there was an area of restricted diffusion in left MCA territory, and the corresponding ASL image showed there was hyperperfusion in this area. And the hyperperfused area was almost similar to that of restricted diffusion area, so there was no ischemic penumbra in this case. And corresponding angiography in this patient showed complete occlusion of the left MCA artery. This was another case of hyperacute infarct. There was complete occlusion of the left ICA, and there was hyperacute infarct which was just developing, and it is seen in the left parietal lobe, and the corresponding ASL image showed a lot of hyperperfusion in the left cerebral hemisphere. So maybe there was ischemic penumbra in this case, and this is non-contrast perfusion, arterial spin labeling. So MR perfusion is also used in grading of glioma. This is a case of a low-grade glioma where there was barely any enhancement on gadolinium study, and the MR perfusion with contrast showed hyperperfused lesion in the right parietal lobe. Also, it is used in differentiating recurrence and post-radiotherapy changes. This was a patient where there was a recurrent lesion after operation almost after 8 to 9 months, and this was a recurrent lesion which was showing hyperperfusion in the right parietal lobe. So the next specialized sequence is MR spectroscopy. It is used for detecting the presence and concentration of various metabolites. It should always be used as an adjunct to the conventional MRI sequences. However, it increases specificity. So the normal curve looks like this, and there's a small choline peak and NAA peak is larger, and the line under which these peaks lie forms an angle of 45 degrees with the baseline, and this is called the Hunter's angle. So various techniques are used in MR spectroscopy. First, there's a single voxel, there is a multi-voxel technique. Single voxel, there is a small area of tissue which is imaged, and concentration of metabolites are analyzed in that. And multi-voxel, there's a larger area of tissue which is imaged, and individual smaller voxels can be used to determine the area concentration of various metabolites. Also, it can be performed on various TEs, which is 144 and 35. So 144, the lactate peak is inverted, there is less of distortion, and a smaller number of metabolites are analyzed on 144 TE. So these are few examples. This was a case of granuloma, which was a ring enhancing lesion in the left frontal lobe, and there was a high lipid lactate peak in this case, so tuberculoma diagnosis was favored over NCC. This is another case of a high-grade glioma. There was a huge choline peak, and lipid lactate peak was also raised, suggesting there was some necrosis in the lesion. So this is about spectroscopy. So CSF flow study is used in NPH protocols in patients of NPH, where we run the sequence and the absolute stroke volume is calculated. So anything about 44 microliters will suggest a good response to shunting. So this is CSF flow study. And the next sequence is diffusion tensor imaging, which is based on diffusion weighted imaging. So it is basically used to delineate white matter tracts surrounding a particular lesion. It helps in pre-surgical planning of various tumors, and it is also under study for Alzheimer's disease and multiple sclerosis. So the last sequence is functional imaging. This is also somewhat in research phase, and it is sometimes useful in pre-surgical patients. So it detects alterations in blood flow in response to verbal and sensory stimuli, and this is what the images look like. So I have basically covered most of the sequences, just an introduction of all. So this is just a revision. Thank you for your patience, and thank you for listening.
Thank you, Dr. Nidhi.